Welcome everyone to the Bridge2AI Voice as a Biomarker of Health webinar series. I'm David Dorr from Oregon Health and Science University, and I am the principal investigator of the module for skills and workforce development under the Bridge2AI. And I'm extraordinarily happy to have James Anibal here to talk to us about some of his interests in AI. He's currently a PhD student at the University of Oxford, an NIH-Oxford scholar, and a visiting researcher at the Oxford University Clinical Research Unit in Ho Chi Minh City, Vietnam. He's also a graduate of Case Western Reserve, where his undergraduate research focused on machine learning algorithms. And now his goal is to create AI-driven diagnostic tools that rely on physiologic waveform data that is easily collected in low-resource healthcare environments. So very important topic for us in voice, since voice is one such waveform. There's many, it's an interest of our study and our efforts to understand this particular topic. So James, I will leave it to you. Thank you.
Thank you so much for the introduction and for having me to give this talk today. So I'm really excited to share a little bit of our work with you. So hopefully everyone can see my screen now. So I am James Anibal, and as David just said, I'm a PhD student at the University of Oxford, the NIH Clinical Center, and I also am a visiting researcher at USF in the Bridge2AI project and OUCRU Vietnam. So my initial foray into waveform data started with photoplethysmography, or PPG waveforms, from wrist wearables that measure cardiovascular and respiratory signals. But as a signals researcher, the rich information contained in very low-cost sound data was very interesting to me, and I felt that it had a lot of applications, particularly in resource-constrained healthcare settings. So I've now expanded my AI research focus into multimodal signals and AI for health. So when we typically think of voice AI, we imagine data that's collected from the human voice, quantifying the way air interacts with the vocal folds. So for example, a participant might say an elongated vowel like ah, and we'll collect that data, and we can train an AI model to connect features of that data with different states of health. For example, COVID-19 positivity or COVID-19 negativity, which was the focus of several large-scale data collection studies that have been done in the last couple of years. And in the case of gold standard voice AI, so voice AI for characterization and benchmarking that's often done in high resource settings, we're able to collect data from a very controlled environment with high quality technology and standardized prompts. And as a result, that data turns out pretty well. It's fairly noiseless, it can be balanced, we can collect exactly what we want when we want it. But this type of data collection may be expensive and time consuming, and a low resource setting is generally not ideal for benchmarking with highly standardized data. That work is obviously extremely important to understanding the nature of sound as it relates to health. But in a low resource healthcare setting, particularly in a pandemic environment like we've just seen, there's often insufficient time or funding for highly controlled research settings. The environments are often not standardized across the different healthcare facilities where we may be collecting data. The devices with which we collect data are not likely to be standardized. Data collection procedures are not likely to be standardized, and the data itself is often sparse or unbalanced with no way to go back and correct for those errors. So a big focus of my research has been how we can transition gold standard voice AI into practical tools that can be deployed in low resource healthcare settings, particularly in Vietnam, where I'm currently working. So that's what I'll be talking to you a little bit about today, with the key research question of how we can enhance the accessibility of voice AI. Before I do that, I'm going to briefly introduce a study that kind of piqued our interest in audio data from suboptimal, less standardized settings. So I'm going to talk a little bit about that study and what we learned from that study, and then explain how we transition that into our study currently, which involves collecting multimodal audio data from a hospital in Vietnam and building AI models that can leverage that data for clinical tasks. So the study where we kind of really first started to explore the inherent challenges associated with audio data from, in this case, a completely unstandardized setting, was actually from YouTube data, so audio data collected from YouTube. And the way we started to look at this data was, rather than just focusing on voice as the traditional way that we look at voice, which is the way air interacts with vocal cords, we started to think of audio as trimodal data, which is voice, speech, and language. And all of these have potential clinical value and are often produced at the same time, which means the way humans communicate is actually a very high value data stream, especially in the context of health. So what we're trying to determine is, if you have AI models that can integrate information from all three of those sources to tell us something about someone's health, will that be a significant improvement from conventional methods, even if the data is from a less standardized, less ideal setting? And we initially explored this with a study involving audio collected from social media sources. And here's just a little infomercial from the NIH that kind of explains the differences between voice, speech, and language. So voice obviously being the sound that's made as our air is pushed between the vocal folds. Speech is the more complex muscle movements that create recognizable sounds and patterns. And then language is at the next level up from that, which is communicating specific knowledge, beliefs, behaviors, and concepts using speech. So when someone communicates, all three of these modalities are present, and all three may have unique implications to the development of clinical AI from sound data. So the question as to why we are why we were initially interested in audio data from YouTube, there are about 500 hours of video, usually with accompanying audio, uploaded to YouTube every minute. And just to give you an example of the sheer magnitude of that data, if 0.003% of that data had valuable health information or information that would be valuable for the development of a health AI model, that would give us 8,760 hours of data per year. And that's in comparison to a lot of existing health voice data sets, which often have less than 10 hours of data per cohort. And of course, there are still huge questions as to the best way to access and leverage and manage this data, but the sheer magnitude of audio data that's present on this platform is certainly worth further study. So our goal with this initial project was to show that social media data from YouTube was a useful source of data or information about emerging pandemic illnesses like COVID-19. And the task that we defined was that we wanted to use multimodal audio data, meaning voice, speech, and language from YouTube, to identify COVID positivity in the speakers. And possible applications for this work were numerous. That includes boosting small data sets with pre-training information, potentially epidemiologically with pandemic monitoring, interpreting the features that we found to identify changes in symptoms over time and variant, and of course, proof of concept for larger studies involving social media data with large language models. And our first step in accomplishing this task was, of course, to figure out how we were going to acquire the data and define the cohorts. So we defined 6 primary cohorts of audio data for the study. The first, of course, was COVID-19 across multiple variants. We also collected videos from the same speakers as those in our COVID cohort when available from both pre and post illness. We collected audio videos for YouTube videos and audio from those with other illnesses that had respiratory symptoms and those without respiratory symptoms. Healthy speakers discussing topics related to COVID-19, like vaccination, testing, or past experiences with the illness, informative videos on COVID-19 and other illnesses, and then completely random topics. So this data set was designed to not only potentially identify unique features of the disease from how people were describing it, but also determine if we could extract COVID-19 videos from all of the rest of YouTube in a potentially fully automated AI-driven fashion. when we consider the diversity, let's say, of videos that are posted on YouTube in terms of the number of possible different types of content that people provide, we needed some inclusion criteria for selecting this data, obviously. So our first inclusion criteria is that all of our videos had one speaker with clearly audible speech, and illness was confirmed either via information in the video or the metadata. We also ensured that for the COVID-19 and other illnesses cohort, the video was taken within 2 weeks of the onset of symptoms. Our final two is that for the COVID topics cohort, they had to be discussing an experience with testing, vaccines, or prior illness, so that they're using a lot of the same vocabulary and the same sentiment as the COVID cohort. Because a huge concern with doing this is that the model would really be excellent at separating between speakers who were sick and potentially discussing their illness and speakers who were completely healthy discussing product reviews. So we wanted to understand if there were nuanced differences between people who were actually presenting with an illness and those who were simply discussing a past experience or a related experience. And finally, to make the data set as standardized as it could possibly be, the corresponding healthy videos for the COVID cohort were preferentially selected for a similar structure as the COVID samples. So if someone posted a quarantine experience video, we would identify the same speaker talking about their experience with something as closely related to that topic as possible. So the resultant data set ended up being thankfully quite large. So we identified 393 COVID-19 videos with a total of 89.2 hours of audio and 195 samples from non-COVID respiratory infections or illnesses with about 20 hours of audio. So this is a significant increase in the amount of available data compared to related studies using sound data for COVID-19 and other pandemic illnesses. And many other COVID-19 data sets were also unable to include other illnesses due to the nature of the data collection. So using social media data for this purpose already provides a number of advantages, including the inclusion of diverse COVID negative samples that range a number of other illnesses rather than just simply trying to compare COVID-19 speech with perfectly healthy audio. So here I'll talk a little bit about the methods that we use to actually make the prediction. I don't want to spend too much time on this because I want to get to the prospective study in Vietnam. But after the data was collected, we removed background noise. We extracted voice alone. So if there were sections of the video that did not contain voice or simply contained periods of silence, those were removed. And then finally, we used YamNet, which is a project that was actually a pre-trained model on YouTube data that allows us to filter speech with different thresholds of confidence. So it allowed us to experiment with the threshold of confidence that that segment of the video was actually human speech. So if we wanted to have only very, very high fidelity samples, we could set that threshold at 0.98, and we were also able to experiment with lower thresholds like 0.8 and 0.75 in order to better understand the trade-off between data quality and data quantity in this case. So once we had the data processed and cleaned up and ready to go, we used a DenseNet convolutional neural network to make the prediction based on the cohort of origin for that YouTube video. And just to be a little clearer about what I meant with the YamNet filtering, YamNet, as I said, is a pre-trained neural network model that is able to predict the type of sound. So it gives us very precise insights into where each half-second segment of our YouTube video came from in the context of the audio. So we're able to not only identify human voice with different confidence thresholds, but also respiratory sounds as well. So it allows us for very precise filtering of our YouTube videos, and it allows us to change the threshold of acceptability for confidence of human voice and respiratory sounds to kind of explore that trade-off between quality and quantity for very large data sets collected from online sources. And thus far, our results for this study, which is currently undergoing peer review, have been very promising. So we've identified at least we've identified the presence of signal in separating between the COVID-19 samples from each of the different subcohorts, including the other illnesses and the COVID topic or the COVID discussion cohort. So what we found is that there's a high potential for using powerful AI models for identifying the large amount of health information or relevant clinical data from online sources and potentially using that to stabilize future pre-trained models for health purposes or providing extra context for future iterations of voice AI in pandemic settings. What we also found is that there were statistically significant performance improvements between the 1 second and 5 second segments of videos for model training. So when we were training our AI model, we either broke the YouTube videos up into 1 second speech segments, which is more conventional, or we used longer segments of speech or audio. And we found that the longer it got, the better the performance was, which is to be expected, I think, because we were using multimodal audio more effectively with longer samples. There was more of an opportunity to capture features from not just the sound, but also the speech, or not just the voice, but also the speech and the language as well, which suggests that even in an environment like YouTube, there's valuable information from across voice, speech, and language towards building clinical AI models. The model performance also declined sharply when training on just one segment per video, even if that segment is a very high fidelity, high quality segment. So what this shows is that collecting, 1 second or 5 seconds or 10 seconds of speech per participant may not be as ideal for supporting model generalization than collecting, say, 1 minute or 5 minutes or 10 minutes of speech where possible, because that diversity of speech, that diversity of audio can act as data augmentation and model stabilization to enhance downstream results. So we learned a lot from this study. The first and most obvious being that social media data, audio data from social media or public sources, even from a semi-manual or low-tech mining process, can yield huge amounts of data. And with the development of the right AI models, we could probably make those data sets much, much larger and provide stabilization platforms for prospective AI models that may be built. We were also able to determine speculatively that social media data has clinical or public health value, and that there may be a lot more information that's yet to be mined that'll give us specific insights on the nature and temporal changes of illnesses. A couple other insights. We kind of figured that initially that having the voice, speech, and language would be a boost to our AI methodology. But given the results, we can say more clearly that domain-driven methods are needed for challenging data sets. So we need to be designing AI methods based on the specific nature of the data that we're collecting, rather than just pulling models off the shelf, because the ability to capture multimodal audio data was a huge benefit in this case, especially given the noise and potential sources of confounding that would have been in YouTube data. So designing methods to handle multimodal audio or whatever specific type of data that you may be dealing with is really essential for improving the performance of health AI in diverse settings. And all of these insights are applicable in low resource healthcare settings as well. In fact, in many ways, the data environment of a public online source is more similar to a low resource healthcare setting than a high resource healthcare setting is similar to a low resource healthcare setting. And I've kind of illustrated that here. When we collect data at the NIH, which is designated for clinical trials, there are a lot of advantages that are not realistic when collecting data from an emergency department during a pandemic. So at the NIH, we have sufficient time for collecting multimodal data. We have complete control over our noise and our environment. We have engaged participants who are there to participate in studies and for no other reason. So they're engaged, they're willing to go back and do data collection again. They're willing to adjust what they give us based on specifically what we need. There's typically a reasonably high health literacy in high resource settings. There's dedicated research staff, and there's consistent access to correlated metadata for audio data like the electronic health record. In low resource settings like overstaffed hospitals or in pandemic or crisis settings, almost none of those things are going to be available. The healthcare staff that's going to be collecting data is not going to have a lot of time. There's going to be really no way to control the noise or environment in a chaotic setting. Participants in an emergency room during a pandemic are really probably not going to be focused on giving you the best data that you want for your study. They have much more important priorities. Depending on the context, there may not be a reasonably high health literacy. There's probably not going to be a dedicated research staff. And again, depending on the context, there may not be correlated electronic metadata. So handling audio data from a completely unstructured source like YouTube gave us a lot of insights that helped us develop voice AI and audio AI methods for low resource settings, which actually has a striking number of similarities with that prior context. So that introductory study that I just described, it gave us a lot of interesting information about unstructured audio data and audio data from chaotic settings. And it also gave us a lot of interesting insights that helped us develop our current study, which is being run as a collaborative effort between the NIH, the University of Oxford, and the Hospital for Tropical Diseases in Ho Chi Minh City, Vietnam. So HTD, as the name suggests, focuses on tropical and infectious diseases. We've collected data from dengue fever, tuberculosis, COVID-19, Mpox, RSV, hand, foot, and mouth disease, tetanus, and a number of others. And it's an extremely talented team of experts on this topic, but the hospital itself is small. And because of the concentrated expertise, it handles a huge patient volume, not just from Ho Chi Minh City, but to surrounding provinces as well. So in that sense, it is a low resource setting in that the patient to staff ratio is not favorable, and there's a lot of overworking and a lot of chaos in many cases, especially in pandemic settings. So the questions that we kind of posed when we were first designing the study is first, where does voice and audio AI fit into the workflow of the Hospital for Tropical Diseases? How can we collect maximal information in 5 minutes? How can we maximize the multimodality of our data coming from different perspectives or different origins may reinforce our model against biases or noise or missing information from just one source. And finally, if we're collecting information in 5 minutes and the information's multimodal, can it be collected in a way that's easy and intuitive for healthcare workers and for patients? And getting buy-in and making it as easy as possible for people who are there for very different reasons than research studies is really essential to making sure that the data set is sufficient for modeling and the subsequent deployment of AI tools that have been developed. So we centered our data collection principle around this statement, which is tell me about your health. Tell me about your health. When the patient answers that question, it's information that they are aware of, it's information that they're there to talk about already, and it includes voice, speech, and language data as the information is being communicated. So we designed a series of sub-questions centered around that main topic of tell me about your health that's meant to approximate time series health records data of an illness. So we have a series of questions where we learn about the patient's health in a way that gives us a longitudinal view of their past health and their current illness. This takes about 5 to 10 minutes, and we're able to augment that with some simple voice data like elongated vowels and the Vietnamese equivalent of the rainbow passage. So when we ask that question or tell me about your health, we're collecting not only the voice data, but speech and language as well in a way that's very intuitive and straightforward for healthcare workers to facilitate data collection and for patients to provide that information without having to fill out complicated surveys or spend 45 minutes participating in a complicated data collection protocol. So as we continue to develop this study, that we're going to have a number of key questions that we want to answer. The first of which is the impact of tonality and tonal languages on audio AI, which is insufficiently studied at this point in time because there's insufficient data sets. So we want to understand how that's going to play a role and how that's going to compare with the voice AI that's been done in the US and Europe so far. We obviously have a lot of interest in the impact of health literacy on audio data that's collected with a Tell Me About Your Health paradigm, because there's going to be differences in reported information that vary between level of education and socioeconomic status and a number of other factors. And we want to ensure that the technology that we collect is fair and unbiased to every potential user. We'll certainly be assessing the feasibility of building this type of data collection into an emergency department or an infectious disease ward, and how that's going to impact the healthcare providers and how they feel about the technology and their overall insights on collecting audio data in this type of a setting. And then finally, we'll be very interested to compare this type of data, which kind of brings together audio and health records, with the conventional gold standard models trained on electronic health records from high resource settings. So being able to collect data in this way poses a lot of really interesting questions, and we're really eager to explore how voice and speech and language can fit into the clinical workflow in a low resource healthcare setting, and in the future potentially serve as a way to improve the efficiency, reduce healthcare worker burnout, and improve patient outcomes, particularly in pandemic settings and low resource areas. So our next immediate steps in the Vietnam study are to interpret our initial findings, our initial data, perform visualization and characterization, and have experts quality check the data to ensure that that initial proof of concept is there. And then from there, we're planning to expand the study into other hospitals across Vietnam and launch similar feasibility studies with partners at multiple sites in the US and around the world, through a web and mobile application that we can use to deploy data collection efforts very, very quickly. So before I conclude, a big thank you to all of my team members who have helped me in building these projects and supported the work wholeheartedly at Oxford and OUCRU Vietnam, USF and Bridge2AI, and the National Institutes of Health. It's very much been a team effort from many different institutions, and I certainly couldn't have done it without all of these wonderful people who have done so much valuable work and contributed so many amazing insights along the way. So with that, I would love to take any questions that anyone might have. I tried to leave sufficient time for questions, so thank you all so much for listening, and I'm eager to discuss further.
Great. Thank you so much, James. That was wonderful. And I think, Andrea, you're going to help with the Q&A?
I sure can. And it looks like we already have a hand up. So Michael Young, please feel free to ask your question.
Thanks so much for the really intriguing and exciting talk. This is amazing work, and kudos to you and the team for bringing it this far. I was curious how your team is thinking about some of the ethical dimensions of AI and voice analysis and informed consent, and how are you counseling the people and participants around what the implications might be, and are you returning results to individuals?
So at this stage, we are not returning results to individuals. We will need additional layers of approval before our AI systems can be used for influencing patient care or decisions in any way. Ethically, I think with all data collection and all development of AI, there's a risk to the privacy of the participants, and that can't be ignored, especially among vulnerable populations. So some ways, obviously, that we mitigate that, in addition to detailed informed consent, is that we specifically instruct the participants not to provide any identifying or personal information when they are giving us audio data. Obviously, there's debate over whether or not audio data itself is personally identifying, but we take every step to limit the amount of personal information that's communicated to us and keep it focused on health, We also apply anonymization technologies to remove personal information should it be present in the data that we collect. So privacy and voice AI, they belong in the same sentence, and we're really working to try and ensure that as much as possible, but there's still a lot of work to be done for sure. And I think that applies across all of AI as well, especially as it becomes more powerful in the era of LLMs.
Thank you. That's really helpful.
Other questions? Well, I would be curious, because a lot of us on this call are part of the voice project, data generation project. And so what are some lessons learned that you would like to share with us as we are putting our projects together?
Lessons learned. I think the biggest lesson that we've learned from transitioning voice AI into this type of a context is that the interface and the way data is collected has to be extremely intuitive and fluid for clinical workflows. So it has to be something that's not just straightforward, but also useful for healthcare workers. When participants are describing their health for our platform, that's also conveying useful information to the healthcare team that they can also leverage and get a little bit ahead. So it possibly saves time. It's also something that's very simple and straightforward for the patients that they were likely already there to do. So in a low resource environment with a lot of patients and not a lot of time, building voice and audio AI into an intuitive workflow is really essential. The other lesson that we've learned is that we just can't be too picky in terms of how the data is collected. It is going to come from different devices. It is going to come from different settings. There is going to be different types of background noise in these types of hospitals. And our job as AI researchers is to innovate the methods that can overcome that, rather than expecting, more funding and time to flow into these contexts. We obviously hope that happens, but we don't want it to obstruct our ability to develop technology that can be deployed in these settings.
Great. I also I'll use the privilege to also ask a question. So one of the studies that we're doing is very relevant to this, and I think there's a draft paper out, which is there some level of which the noise was too high to get the signals, and did you develop some ways to detect that? Maybe specifically, I really enjoyed the idea that you could take YouTube videos. Did you learn something about, for instance, the encoding variation that exists in YouTube videos that really impacted your ability to pull this out? Is it encoding? Is it just there's some level of background noise that's too problematic? Or were you able to get some signal from almost anything?
Well, can you clarify what you mean by encoding?
Yeah, so in YouTube, what's interesting is if you are sort of a popular creator, they will allow you to use a much higher quality codec. So your video and audio is much higher quality than somebody who's has a lot fewer followers, and so it's just like naturally lower quality, which you can see in the variety of people. So like even you could see it by the number of videos they've uploaded or the number of followers that they have, that you'll see a lot of variation in sort of the underlying quality.
That makes sense now. And when you said encoding, I was initially thinking about the model encoding, but that makes sense. So to answer your question, yes, you're absolutely right. And thankfully, our cohort is a pretty good mix of popular influencers and people who I was the only viewer of the video. So there was quite a range. And while we didn't learn anything about that in particular, we feel that it wasn't necessarily a bias to our model either, because each cohort had a fairly balanced mix of, influencers who had 5 to 6 million subscribers and people who had one subscriber, and it was themselves. So there was a good mix of diversity there. But yes, it would certainly be interesting, in the future to kind of map out the differences, because that applies for the low resource context as well, where some sites may have iPhone 15s and other sites may have, much cheaper, lower quality mics, and there's likely to be variation there. So that's something we're planning to keep in mind and collect information on the device used to collect data when we perform subsequent studies.
Thanks. So I see 2 hands up, and then we'll address the comments in the chat. So Bill, do you want to go first?
Sure, thanks. Thank you, James. This is a very interesting talk. I'm also at OHSU. I'm part of the Voice AI project. And I'm going to ask you a question, not meaning to be snarky, but when you were talking about differences in the background, it brought in my mind to some of the image classification studies that are basically contaminated by extraneous markings or other artifacts of the image that have nothing to do with the specific diagnosis. But because these models measure everything, that they actually get biased for certain diagnoses that might be more common in a certain setting and so forth. So I'm wondering if there's any kind of control around it may be that a hospital in a certain province of Vietnam has a certain kind of background information, or maybe even the people of a certain ethnicity have a given difference in their voice. Is there any way to control for that sort of thing, which may impede the generalization of the model if you want to move it out to other areas of Vietnam or transport it to the US or whatever?
So it's a big question. I'll try and answer it in stages. The first and most important component, I think, of working with AI and data and healthcare is the issue of interpretability. So using attention-based models where we can kind of understand which regions of the waveform were used to make a decision and potentially interpret those and understand where they came from. That's obviously the best way to protect against what you just described. And had the imaging studies that you referenced, had there been some sort of interpretation of the deep learning models, as there ultimately was too late, that would have been detected almost immediately, and the data could have been restructured to avoid that. So at the top of our priority list for reducing the risk of that is interpreting what we find and making sure we can convey clearly where the signal is coming from. Back to the data collection itself, while I do think that it would be somewhat unlikely that the model would generalize to specific conclusions based on background noise in hospitals with extremely diverse cohorts of diseases and backgrounds. That's something that we try to address as best as possible with our pre-processing and denoising methods and our YAMNet to extract high confidence speech segments. So removing that as much as possible is a great step that can mitigate those types of biases. And now I think to the final portion of your question, which was about biases based on ethnicity. For that, there's actually a huge field of work being done in the AI space, including in my lab at Oxford, with methods that we can build into AI training to ensure, while they are training, that they are not learning information that is unique to ethnicity that would result in a bias against certain groups. So we can debias those large models during training, and we certainly will do that once our cohort becomes large enough and diverse enough for that to be feasible. I hope that answers your question somewhat.
Yeah, great.
Directly.
Thanks.
Hey, I'm going to move over to the chat for a second because there have been people waiting patiently. First of all, can you provide your email in case anyone wants to send you any follow-up questions? That is a question in the chat. You can tell me offline if you
just posted my email in the chat. I'd welcome any follow-up questions or discussions.
Thank you. And somebody would like to know if singing plays a part in any of the type of audio data that you use, or would that fall under voice? They write, I would think some form of vocal range would provide some interesting results in your data.
I'm sure that it would. I think, though, most of our data involves speakers and people who are monologuing. People with COVID didn't tend to be in a singing mood, is what we found. So most of it was people speaking.
Great, thank you. And do you try to keep your subjects in a particular age group?
We do not, because obviously we look for diversity in age group, but we don't try and keep them in a specific age group because our ultimate goal is to develop technology that has real world deployability potential in a low resource setting. And hospitals that deal with tropical illnesses deal with patients who have those illnesses, who are quite young and who are very, very elderly. So we want to develop technology that's as encompassing as possible.
Great, thank you. And somebody would like to know if you could detail the de-identification techniques that you use.
So I wouldn't go so far as to say de-identification, because the nature of voice data as a personally identifying blueprint is something that's widely discussed. I'd say what we do is we reduce the amount of personal information in the data as much as possible if it's provided accidentally or caught in the background. So we'll move through the transcriptions, for example, of the data we collect. And if anything pops up that's a name or an address or anything sensitive, that will be removed and completely deleted from our data set. So while we're not trying to make a determination as to whether voice is a personally identifying blueprint, we can use large language models to remove and eliminate personal identification, personal information that may be given accidentally. And in doing so, hopefully do the best that we can to protect the security and privacy of our participants.
Great, thank you. And then I have another question from Andrew Williams. His hand is up.
From the chorus group, we're looking at other kinds of waveforms, not auditory. And I have two questions. The first, and I apologize, I missed the first part of your talk, and hopefully this isn't a question you covered there, but was the labeling and training focused primarily on the ability to distinguish attributes on a single instance of someone's vocalization, or was there the ability to train on change within an individual? And I'm interested in that potential to, I guess, model the importance of change with there's multiple samples from an individual over time, as that might play out in either low resourced or high resourced settings where you're getting samples. And the second question is about transfer learning. I guess your interest in transfer learning to other kinds of waveforms that might be collected on patients.
So to answer your first question, I completely agree with your assessment of time series, and I often describe in AI contexts, we predict disease as drift, meaning a change from baseline, and not as a cross-sectional snapshot, because there's so much diversity in how patients are when they come into a healthcare setting. And for our voice study in Vietnam, that's certainly something that we're trying to take into account. Obviously, for a feasibility study, we'll just be collecting initial information, but we do ask participants about their past health history. So even if we don't have a voice sample from the past, we have a description of how their health was, and we can use that to contextualize changes in voice. In the future, we'd like to introduce the concept of like a waveform EHR, where when patients come in for primary health appointments, samples of waveform data, including voice, are added to their record so that we can map that over time. We could also certainly use voice as a monitoring mechanism over the course of a hospital stay for mild or moderate illnesses like COVID-19, and that's something we're looking at as well. So for the YouTube study, unfortunately, the challenge there was, in terms of doing it longitudinally, many of the videos people posted before they were ill did not at all match in tone or subject as the videos people posted when they were ill, which led to kind of some artificial, signal, I think. So it was important to do that study from a population perspective as well, where we were comparing speakers with COVID to speakers who had other illnesses and speakers who did not have COVID, rather than someone talking about their illness or laying in their bed compared to when they were reviewing products that they got at Walmart. So we had to kind of take it both ways because of that artificial signal that YouTube introduces. But for the prospective study, we're absolutely adding in longitudinal components. For your second question about transfer learning, I would say, given the domain differences between different types of signals, that transferring information from voice signals onto cardiac signals is unlikely. With that said, I think where we're focusing is correlating them if possible. There's this, we have a lot of photoplasmography waveforms and ECG waveforms from the site in Vietnam and other sites as well. And ultimately, it would be very interesting to explore mutual information and information gained from having multiple types of waveforms, which are fundamentally very low cost to collect, being looked at by the same model at the same time.
Thanks. That's fascinating work, and yeah, the prospect of being able to get samples, people who are in a healthcare setting, in a healthy state for a wellness visit, for they're there to get their health checked, but there's no motivating symptoms driving their health-seeking behavior, and using labels that indicate states of health from the EHR, the associated EHR setting, and then distinguishing it from samples collected during different disease states it seems like a really intriguing potential. Thanks for sharing your work.
Alex, do you have a question?
Yes, James, excellent presentation. I'm fascinated by your, I could talk for hours about the project. What I'm interested to learn a little bit is bias from pulling signal from a specific platform. So YouTube, for example, would use compression on both video and audio, and would that introduce any bias in the signal that you are capturing, right? And also, the data that you analyze, for example, for COVID, has inherent bias of what a patient reported, like I got COVID or I didn't get. The things that I would like to know is, how are you addressing these issues towards developing your models? And more importantly, if you were to do this in the future, how would you prevent these biases? And a lot of that you covered about the amount of curation that you have to go through this, but is there a way that you can, there is not a surefire solution, but like an approach as a best practices on how to, clean up these rough diamonds that are out there in the wild? Like, this is a huge data set. Mm-hmm. How do we make best use of it, essentially?
Absolutely. So the first part of your question about how YouTube uses compression and other sources of, or other social media platforms or sources of data may not. The solution there, unfortunately, what YouTube does to its audio before we access it is kind of irreversible and intractable in that way. So the best way to overcome that would be to have balanced cohorts from multiple different sources. So if there's going to be noise in your data set, it should at least be randomly distributed amongst your cohorts so that it's not, mistaken as signal. So if we were able to collect data from multiple public sources and that data was evenly distributed between our cohorts, then we wouldn't have to worry so much about that. But it is possibly a source of bias in terms of transferring the YouTube knowledge onto other sources, and the jury is still out as to the impacts of that. But I'd say the solution to that problem is actually to make the data set bigger, pull from other sources as well, and diversify the public sources that you're using so that the different types of noise are randomly distributed and the model is essentially forced to ignore them. Because if there's no signal in a feature, then a neural network can't converge towards that feature. The second part of your question, can you remind me of the second part?
Yes, it focuses on best practices, yes. And especially when the data on social media are patient reported, right? There's no, are we biased? And the curation that we go through, maybe there's overlap with someone else talking. Did you listen in all the hours that you went through to manually annotate this? This sounds like a horrifying experience. So how does someone go to polish the diamond?
There are two answers to that question. The first answer is that all of our quality assurance of all of the pre-processing and filtering of the data was done automatically. So removal of background noise, ensuring speech, mining for certain keywords and topics, removing periods of silence, removing music, removing multiple speakers. All of that can be done with AI, and that's detailed methodologically in our manuscript. And you can actually get a very chaotic YouTube video to just a single clear monologue fairly accurately using a series of AI techniques, particularly pre-trained models that were developed by companies with access to large amounts of audio, like the YamNet model. With that said, even despite doing all that, because this was a proof of concept study, our team did review every single video to make sure that I could say that to you honestly. So for the proof of concept, yes, we actually did review every single video. We checked to make sure that the cohorts were labeled properly and that our automated techniques were performing well.
That answers it. No shortcuts.
It wasn't a lot of fun.
Thank you.
I think I'm going to give Mel the last word. She has her hand up.
Thank you. Okay, I'm off mute now. Thank you so much for your presentation thus far. As everyone has stated, it's very informative, very interesting. My question for you is, going back to the beginning, you mentioned the phrases or words that that you were training it on with the initial YouTube videos. And I know in the States, there was a demonetization policy whenever a creator brought up COVID-19. Considering language is such an integral part of voice, were there any colloquial terms thrown in for COVID-19 during the initial review?
So again, having checked out a lot of them, it was pretty evenly distributed between people who were using it as an opportunity to talk about their illness very straightforwardly and discuss, symptoms, or people who barely mentioned it at all, or people who did indeed use colloquial terms like Rona was a big one to try and avoid those filters. And again, this was one of those things where, given that we were relying on data posted on YouTube, it was hard to control for that. We can't go back to our participants and say, please say COVID. But it was, again, fairly balanced. And we had a very wide range of speakers, ranging from, folks who were quarantining at facilities in the Philippines to influencers who were in their penthouses talking about their experience with the virus. So the nice thing about YouTube is also the worst thing, in that it's extremely diverse, it's extremely varied, which introduces noise, but it can also help account for some sources of noise, because it's very unlikely that one of your cohorts is going to have one defining erroneous feature, because it's just so varied.
Thank you so much.
Right.
There was one final question in the chat. Did you want me to address that before we wrap up?
Oh, yes, I think so. Really quickly, if you don't mind.
Absolutely. So the question is how we approach individual consent in the context of scraping or taking YouTube videos. Obviously, all of the YouTube videos that were scraped were public. They were not unlisted. They were not private videos. So we don't have access to those through the YouTube API. And our IRB determined that in this context for this project, social media data, YouTube data, was public data, and that consent was not required in this case. And our IRB did, of course, review this study, and that was their determination.
Thank you.
All right. Well, James, thank you so much. And Andrea, thank you for helping to run the Q&A. And yes, look out for a survey from us. And we will see you at the next one.
Thank you. Thank you, James.
Thank you so much.